Hello. Thank you so much for that kind introduction, I'm assuming. This is Rick Wiggins from the University of Utah, and I'm going to follow up next by talking about the best of the best and the worst of times, my best diagnostic cases. I have nothing significant to disclose. When thinking about this, there's a lot of reasons why something may be the best at something. And I kind of changed this talk up completely because there are a lot of different reasons to think about why something might really be good. So we're going to look at what are some good spine diagnostic cases, look at some important imaging features and best differentials for these cases. There's a lot of different reasons why something might be the best. And when I started putting this together, I was thinking more and more about what makes a good case to show it something and what I personally liked the best about something. And there are a lot of different reasons for that. Sometimes it's just good imaging, if the guy really holds still well, or it's a good story, things that follow rules, things that don't follow rules. There are a lot of different reasons why something might be a really good case. But I do want to thank everybody so much for coming to Nollins for this exciting virtual conference. Stupid COVID. So the first case was a 36-year-old guy who had a 10-year history of increasing upper extremity weakness. And we did plain film that weren't exciting. Then we did a CT and saw kind of a weird calcified thing. And then we did an MR. And here are the T2 sagittal and the T1 post. And you can see that on the bone algorithm reconstruction CT, we had high density, almost calcified looking lesion. It was very dark in the T2 and kind of avidly enhancing. So this was a nice case and good examples. And we were coming up with all kind of weird different differentials for that. If you've seen something like that before, it's just a big meningioma. And this was kind of interesting for a couple of reasons. One is we just had nice correlating modalities. It's not always nice when you have good plain film CT and MRI, and a good example of something following the rules. But also it's an interesting concept when we think about pathology in an unexpected location. If this was something intracranial and extraaxial that was calcified very dark on the T2, we know that T2 is a good rough marker of tumor cellularity, and it was avidly enhancing with dural tails. That would be perfect for a meningioma. But if you take that same lesion and put it in a different location, it becomes sometimes a much more complicated case, and it may lead you down a very different pathway when you're thinking about differentials. So I just thought that was a nice case. So the next case I had, this is a 60-year-old woman who showed up with neck pain and very nice correlating plain film on CT. Both plain film and CT, we see all this high density calcified posterior to the vertebral bodies. And we did an MR that very nicely correlated the T2 and the STIR and the T1 MR, all very dark signal intensity for that same area. Not a big question about differential, a good example of OPLL, ossification of the posterior longitudinal ligament. But it was very nice because we had plain film and CT and MR that all correlated very nicely and well. And we also had postoperative. So we saw this postoperative decompression where you could still actually see the OPLL on the plain film. So that was nice because we had correlating modalities. We had plain film CT and MR that all showed very nicely this thing. And it highlights, especially around the skull base, how sometimes if we have a CT and an MR, we can tell you exactly what the pathology is. That's very interesting. But also we could have the postoperative discussion where we think about this OPLL like keloids. You don't want to cut it out because it comes back worse. So you just do a posterior decompression. You don't actually do surgery on the lesion. You do surgery on the anatomy around the lesion so that the body can go around it. So that's an interesting kind of pathology and nice correlating imaging. So next case was a 45-year-old gentleman who said he had a 3-week history of increasing low back pain going down both legs. Plain film and CT both showed high density, not only in the vertebral body, but kind of the vertebral bodies above and below and posteriorly in the spinous process and the vertebral body. So that was kind of interesting. So we decided this guy had a gadolinium deficiency that we needed to correct. So we did an MR. And it was kind of bright on the T2. It's kind of strange that it was in the vertebral bodies and almost completely sparing the discs. There's something in the soft tissue in front. It's encroaching the central canal. Very bright on the STIR there at that location. We did the T1. It was very dark. We gave him GAD, and it was enhancing, not a whole lot, but enhancing a little bit. But again, very strange signal intensity kind of around there. Then we did a diffusion and ADC. It was kind of dark on the ADC, but not really. I'm not sure this helped us or hurt us or anything else. And there was kind of a soft tissue component around the outside. So we were really scratching our heads over this and having a long, drawn out discussion about all these different things and coming up with some real zebras for passable pathology. And at some point, somebody looked at it, who's someone very smart, and they looked at this and said, oh, it's a vertebral body thing that's expansile and it's bright on T2, so it's probably a chordoma. And it turned out that's what it was. It was a chordoma. So that was a good example, not only of nice imaging, but it was a good story. And it's a great thing. Anytime you can learn from somebody else's pain, that's great. And following the rules. It's an osseous expansile thing. Certainly if it was in the skull base, it was bright on T2 and expansile, we would think about that. And it reminds us that we do have a lot of fancy sequences we look at, especially in the brain with all these MR perfusions and DCE and DSC we can do. But the plain old basic T1 and T2 series actually give you a lot of information if you just pay attention to them. So don't ignore that T1 and T2, and especially the T1 pre around the skull base and the spine. Don't stop doing those. So the next interesting case we had, this is a 38-year-old man who came in with low back pain. Anytime I look at a sequence and I'm not sure exactly which sequence it is, I find that interesting. And when it's a huge mass, that's great. This is actually a T2, a T1 before contrast and the T1 after. I thought at first that this was a T2. It looked like there was a mass filling the cord at that location. So I thought this was just a very nice example of a case. You've got a kind of an extensive enhancing intradural, maybe extramedullary mass that's going from the conus all the way down to the sacrum. You've got erosion of those sacral osseous structures from expansion of the lesion. And then on the MR, we actually did a T and an L spine, and you could actually see what looked like leptomeningeal enhancement. So it's kind of the opposite of drop mets. This is something going up from subarachnoid spread at that location. I thought that was very interesting. So this case, if you just have the thing around the cord, it's great for myxopapillary ependymoma. But things that are really big and nice correlating examples of nice and new concepts, things like this with leptomeningeal spread and enhancement is kind of interesting. So I thought that was a good case because it had some classic findings, but also some new findings and reminding us of drop mets, not only from intracranial pathology going down, but things that are down low that may go up. So that was interesting. Next case here was a patient who came in with complaints of sinusitis, and the head and neck guys were talking about some kind of sinus disease. I don't know what exactly, but I was looking at the scout and I said, yeah. But what about this? The space between the dens and the anterior arch of T1. So we ended up doing an MR, then we saw the gap was too wide there and a lot of fluid. And we did flexion extension and we were like, oh my goodness, look at that. And I don't know if you've ever had the experience that you're doing one of these flexion and extension cases under fluoro. And when you think about that complex anatomy that's around O1-2, and the subtle ligaments that all hold those into place, you may have had the opportunity where you start doing a fluoro study and then you immediately run in the room and start screaming, oh my God, stop turning your head, don't move at all. That's kind of it. Oh my God, please stop. That's kind of exciting. So next case we had, that woman who came in, she had a lot of ligamentous injury and ended up actually getting fused in that case. So I thought that was interesting. Certainly not what she came in for. She came in with sinusitis symptoms and ended up getting fused back there. So it's a good example of don't ignore the scout. And also it's a good story. And it's a great example of how significantly we change patient care when we pay attention to things. So don't ignore the scouts on the CT and don't ignore the scanograms on MR. Sometimes that's the only place that you'll see the images, findings. So next case, a 42-year-old guy came in with neck pain and we started asking him all these questions and he said no to everything. He didn't have primary tumor. He didn't have a history of any systemic pathology. The plain film was really messed up. We did an MR and everything was just all this pathology. We didn't understand what was going on. He denied any history of any problems or drug use or neoplasm or METs or anything. So he did an MR of his C-spine, and we saw this bright signal, prevertebral soft tissue swelling. We're destroying the dens, the tip of the clivus. Again, all those subtle ligaments around O1-2, very confusing. And then over a couple of weeks, we saw this significant ligamentum laxity that was destroying the structures, like he was trying to pith himself with his dens around the skull base. And especially out laterally, we saw the O1-2 junction with these facets really eroding into each other significantly at that level. And so this case ended up kind of being a good story out of example. It turns out he was an IV drug user with positive blood cultures. Of course, you don't get those blood cultures till later, but it was a good story because one of the patient's visitors who showed up, we actually took the visitor aside and we got the visitor to admit that he did have a history of IV drug use. So it totally changed our patient care in that case. It was just a nice example. I think also the significant change over just a couple of weeks, how everything started to just completely destroy that site that we had significant infection from his positive blood cultures. So next case, this patient came in, a 40-year-old woman with low back pain. She said her low back pain started after a fall a few months ago. And we looked at the plain film and there was all this mass effect and bowing of the wall. So he said, I don't know what this is, but this patient has an SGO. There's something going on. So we decided we needed to look at these bones better. So we thought we'd do a CT. And you have kind of non-aggressive, erosive, expansile changes, scalloping of the back of the vertebral bodies and sacral elements. So kind of benign appearance. But this machine is just a big, stupid densometer. We're just looking at densities of stuff. So sometimes we look at that and we say, you know what? This guy has a gadolinium deficiency we need to correct. And we go ahead and we spin his protons and we get an MR. This is a big lesion. It's a lot. Most of it was bright on T2, and it looked kind of like there was half of a golf ball back here that was dark on T1 before, and it was enhancing after. And same thing on the axials, this enhancing nodule. And I had a pretty big differential for this, but one of the most important things I started thinking was, you know what? There is no part of the body that cannot be reached with an 18 gauge and a stiff arm. So we decided we needed to put a needle in that thing. And the pathology came back as something that I did not expect. That actually came back as a tail gut cyst associated with a carcinoid tumor. Now, I think it's kind of interesting the World Health Organization gets together every 7 years or so and seems to come up with pathology that did not exist the year before, but I still find new things every now and then that I hadn't heard about. So this was an interesting case because we had nice correlating plain film and CT and MR, and anything that's really big is a nice case. But I'm always suspicious of these pathologists. They must have much better lobbyists because even though everybody expects their radiology report within a half an hour, somehow the pathologists have convinced everybody that a 1 to 2 week turnaround time is totally normal for their reports. And I think you're looking at the cells, right? That should be the gold standard. So the next case was a kind of a complicated one that was drawn out, but this 59-year-old gentleman came in with back pain, and he had some plain film that was read out as a suspected fracture because there was some irregularity kind of around the dens on the body of C2, and they weren't quite sure what was going on around that area. So they decided to do a CT. So they do a CT, and there's kind of a big cyst there, maybe not a fracture. So we did this workup, but it's really not a fracture, so he doesn't have trauma history at that level. But it looked like he did have some big osteophytes, and we weren't sure about the central canal, so we decided to spin his protons. We do an MR, and we got the T2 and the STIR and the T1, and the central canal does look pretty tight at a couple of levels up there. It's actually pretty wide, though, up high at the posterior aspect of the dens. So he continued to have some neck pain. They repeated his CT. We read it out as no change, but he did have some pretty big osteophytes back there. So they decided to fuse him back posteriorly at that level. So he got a posterior fusion. We got some wires and a whole bunch of screws that are going in there, and the lateral masses of 1, 2, 3, and 4 at that level. And over time, we were just following this guy up. So we looked at his fusion plain film post-op. You see the clips are still in, so we're probably within 10 days here. We see those screws, they look pretty good. We followed up later. You can see the wires and the screws, no significant change. We did some flexion and extension, and that level looked okay, but there's still a question down low. He had some posterior osteophytes, and he was still kind of having the same pain after this surgery about a year or so later. So we kept trying to evaluate him. We repeated the CT. He said he was still having a lot of pain. We did more flexion extension views. It was kind of read out as no change, but we decided to do an MR to try to get a better look there. And we did the MR. I said, well, he is fused back there, but it's still kind of tight down here lower, maybe 4.5 and 5.6. We have some posterior osteophytes and disc complexes. Maybe we should try to help that. Maybe we can fuse them there at that level. So they decided to fuse them anteriorly. I don't know about you, but it seems like to some people, fusions of the spine are kind of like Pringles or Doritos, that you want one and you just want more, and it's hard to stop after a while. So they fused them anteriorly. They had a pretty good result, looking like on the plain film at that level. And again, we did some flexion extension views. It looked kind of like maybe the screws were at an odd angle, not quite sure what's going on there. He said he still had some pain though, so we did a CT to try to evaluate it. It looked like it was okay. All his hardware was intact. They read it out again as no significant change. But there are some levels down low that hadn't been fused yet. Maybe we can go ahead and fuse those levels. So they fused them again posteriorly, tried to do a bigger decompression up higher. So he's had 3 different fusions at this level. Now they followed up after that and they said, well, oh, now we see some broken screws up here. So these screws are broken. Flexion extension, they might have been moving a little bit, but down lower, they thought it was okay. So we did a CT. We said, yeah, sure enough, there is some lucency around those screws that are broken up high. So that makes sense. We did all these fusions and big fusion masses trying to fix that problem. And we kept following up. And he came in again a year later, and he said he was kind of having some increasing pain in his neck and weird sensation down his arms. He didn't know what was going on. And they kept following him up and looking at those broken screws and the fusion. They didn't make too much of it at the time. Again, a year later, still following up. He says the neck pain is getting worse. Not sure what's going on. We kept doing flexion extension views. Yep, broken screws, but everything else looks about the same. No change, no change. Came in later for some sinus complaints, and those head and neck guys were talking about some kind of mucosal thickening. I don't know what, talking about non-obstructive disease at that level. But then they kept doing a spine workup next year. Again, broken screws, all the other fusions they thought was okay. They read no change, no change. A year later, I read out one of these plain films and I'm looking at it and I'm trying to figure out what exactly is going on back here where these screws are broken. I don't understand what this is. And my fellow that day said to me very professorially, those are called cerclage wires. We use them to hold the bone in place. And I said, well, yeah, I know that, but where are these cerclage wires going? I don't understand what's going on back here. It doesn't look like they're wrapping around stuff. And a lot of these are loose around the screws. I don't understand what's going on around here. So we decided to try to look at that better. So we did a CT. So again, we saw the lucency around those screws and the broken screws up high. But then I started looking at, what is that? What is this thing doing? It looks like this wire is sticking right in the central canal. I don't think that's supposed to be there. And I went back and looked at all the prior studies. And in 2010, this was intact. And the next year, we actually had a broken wire right there. And going back and looking at all these studies, you could see that that wire was broken over and over again on multiple studies that we just cavalierly read out as no change over and over again. And on that sinus CT that he had, there was this wire sticking right in the middle of the cord. And we said, I don't know what to do with this. It looks like you got a broken wire sticking in the cord. And the surgeons asked, can we do an MRI? And I said, I can do an MRI. So we decided to spin his protons. And he had all this bright signal in his cord. I was really impressed with that. You could not only see all the signal, but you could actually see the wire that was sticking right in the middle of his cervical cord. I thought, that's an exciting thing. So they decided maybe we should take out the wire. I said, good guess. And interestingly, we imaged the guy a year later, and it looked like it had all resolved. That was great. All that signal went down and went away. So why is that an interesting case? Well, I think it's a great story, and it's great correlating images. And it reminds us of when we think about red flags, has something changed? Is there new pain? Is there increasing pain? Just like, is there a new cranial nerve deficit, new finding in the extremities, new increasing weakness, or something else? Even if the imaging looks about the same, be aware of red flags and changes in the clinical story. So it looked pretty good. Then we had all that signal, and amazingly, it went back to normal. So don't ignore that clinical information, but also it's a great example here of the concept of abnormal stress on normal anatomy and normal stress on abnormal anatomy. Because this guy had all these fusions at different times, it was changing over and over again. And I got to say, I'm constantly amazed at the ability of humans to tolerate imaging injuries, and their ability to recover is very impressive. So that's some random thoughts on some cases that I thought were interesting over the year. There's a lot of different reasons that a case may be good or interesting to you, but those are just some examples that I thought I would like to share with you. And I thank you very much for your attention.